Hello and welcome to my YouTube channel. Today we are going to see general approach to trauma patients. The treatment of seriously injured patients requires rapid assessment of injuries and institution of life-preserving therapy. Because timing is crucial, a systematic approach that can be rapidly and accurately applied is essential. This approach is termed the initial assessment and includes the following elements. Triage. Primary survey, ABCDEs, resuscitation, adjuncts to primary survey and resuscitation, consideration of the need for patient transfer, secondary survey, head-to-toe evaluation and patient history, adjuncts to the secondary survey. Continued post-resuscitation monitoring and re-evaluation, definitive care. The primary and secondary surveys should be repeated frequently to identify any change in the patient's status that indicates the need for additional intervention. Patients are assessed, and their treatment priorities are established, based on their injuries, vital signs, and the injury mechanisms. In severely injured patients, logical and sequential treatment priorities must be established based on overall patient assessment. The patient's vital functions must be assessed quickly and efficiently. Management consists of a rapid primary survey, resuscitation of vital functions, a more detailed secondary survey, and, finally, the initiation of definitive care. This process constitutes the ABCDEs of trauma care and identifies life-threatening conditions by adhering to the following sequence. A. Airway maintenance with cervical spine protection. B. Breathing and ventilation. C. Circulation with hemorrhage control. D. Disability, neurologic status. E. Exposure or environmental control, completely undress the patient, but prevent hypothermia. F. Fast or focused assessment of sonography in trauma. This prioritized sequence is based on the degree of life threat so that the abnormality that poses the greatest threat to life is addressed first. A quick assessment of the A, B, C, and D in a trauma patient can be conducted by asking the patient for his or her name, and asking what happened. Appropriate response indicates that there is no major compromise in A, B, and D. Airway maintenance with cervical spine protection. Upon initial evaluation of a trauma patient, the airway should be assessed first to ascertain patency. The easiest way of assessing airway patency is asking the patient his name or get him to talk. This rapid assessment for signs of airway obstruction should include suctioning and inspection for foreign bodies and facial, mandibular, or tracheal, laryngeal fractures that can result in airway obstruction. Measures to establish a patent airway should be instituted while protecting the cervical spine called inline stabilization. Initially, the chin lift or jaw thrust maneuver is recommended to achieve airway patency. In addition, patients with severe head injuries who have an altered level of consciousness or a Glasgow Coma Scale (GCS) score of 8 or less usually require the placement of a definitive airway. While assessing and managing a patient's airway, great care should be taken to prevent excessive movement of the cervical spine. The patient's head and neck should not be hyperextended, hyperflexed, or rotated to establish and maintain the airway. Based on the history of a traumatic incident, loss of stability of the cervical spine should be assumed. Neurologic examination alone does not exclude a diagnosis of cervical spine injury. Initially, protection of the patient's spinal cord with appropriate immobilization devices should be accomplished and maintained. Cervical collar should be applied until cervical injury is ruled out. Assume a cervical spine injury in patients with blunt multisystem trauma, especially those with an altered level of consciousness or a blunt injury above the clavicle. Breathing and ventilation. Airway patency alone does not ensure adequate ventilation. Respiratory rate, saturation, and air entry should be checked. Adequate gas exchange is required to maximize oxygenation and carbon dioxide elimination. Ventilation requires adequate function of the lungs, chest wall, and diaphragm. Each component must be rapidly examined and evaluated. The patient's neck and chest should be exposed to adequately assess jugular venous distension, position of the trachea, and chest wall excursion. Auscultation should be performed to ensure gas flow in the lungs. Visual inspection and palpation can detect injuries to the chest wall that may compromise ventilation. Injuries that severely impair ventilation in the short term include tension pneumothorax, flail chest with pulmonary contusion, massive hemothorax, and open pneumothorax. Appropriate measures including putting the patient on oxygen to maintain saturation, chest decompression for tension pneumothorax should be done while assessing breathing and ventilation. Circulation with hemorrhage control. Circulatory compromise in trauma patients can result from many different injuries. Hemorrhage is the predominant cause of preventable deaths after injury. Identifying and stopping hemorrhage are therefore crucial steps in the assessment and management of such patients. Once tension pneumothorax has been eliminated as a cause of shock, hypotension following injury must be considered to be hypovolemic in origin until proven otherwise. The elements of clinical observation that yield important information about the patient's hemodynamic status within seconds are level of consciousness, skin color, and pulse. The source of bleeding should be identified as either external or internal. External hemorrhage is identified and controlled during the primary survey. Rapid external blood loss is managed by direct manual pressure on the wound. The major areas of internal hemorrhage are the chest, abdomen, retroperitoneum, pelvis, and long bones. The source of the bleeding is usually identified by physical examination and imaging, for example, chest X-ray, pelvic X-ray, or focused assessment sonography in trauma or fast management may include chest decompression, pelvic binders, splint application, and surgical intervention. Definitive bleeding control is essential along with appropriate replacement of intravascular volume. A minimum of 2 large caliber intravenous IV catheters should be introduced. Blood samples taken for cross-match as well. IV fluid therapy with crystalloids should be initiated. A bolus of 1 to 2 liters of an isotonic solution may be required to achieve an appropriate response in the adult patient. If the patient is unresponsive to initial crystalloid therapy, blood transfusion should be given. Disability, neurologic evaluation. A rapid neurologic evaluation is performed at the end of the primary survey. This neurologic evaluation establishes the patient's level of consciousness, pupillary size and reaction, lateralizing signs, and spinal cord injury level. The GCS is a quick, simple method for determining the level of consciousness that is predictive of patient outcome, particularly the best motor response. A decrease in the level of consciousness may indicate decreased cerebral oxygenation and/or perfusion, or it may be caused by direct cerebral injury. An altered level of consciousness indicates the need for immediate re-evaluation of the patient's oxygenation, ventilation, and perfusion status. Hypoglycemia and alcohol, narcotics, and other drugs also can alter the patient's level of consciousness. However, if these factors are excluded, changes in the level of consciousness should be considered to be of traumatic central nervous system origin until proven otherwise. Primary brain injury results from the structural effect of the injury to the brain. Prevention of secondary brain injury by maintaining adequate oxygenation and perfusion are the main goals of initial management. Exposure and environmental control. Undress. The patient should be completely undressed, usually by cutting off his or her garments to facilitate a thorough examination and assessment. Log roll. Log roll should be done here by at least 3 healthcare workers, 2 for rolling the patient and 1 examining. So, examiner should 1. Palpate vertebra from cervical till lumbosacral area for any tenderness or deformity. 2. Check for any open wound at the back. 3. Do rectum examination to assess for tone and any blood on examining finger. Warming. After patient's clothing has been removed and the assessment is completed, cover patient with warm blankets or an external warming device to prevent hypothermia in the trauma receiving area. Intravenous fluids should be warmed before being infused, and a warm environment room temperature should be maintained. Adjuncts to primary survey. Adjuncts that are used during the primary survey include electrocardiographic monitoring, urinary and gastric catheters, other monitoring, such as ventilatory rate, arterial blood gas (ABG) levels, pulse oximetry, blood pressure, and X-ray examinations, for example, chest and pelvis. Secondary survey. The secondary survey does not begin until the primary survey (ABCDEs) is completed, resuscitative efforts are underway, and the normalization of vital functions has been demonstrated. When additional personnel are available, part of the secondary survey may be conducted while the other personnel attend to the primary survey. In this setting, the conduction of the secondary survey should not interfere with the primary survey, which takes first priority. The secondary survey is a head-to-toe evaluation of the trauma patient, that is, a complete history including mechanism of injury and ample history and physical examination, including reassessment of all vital signs. Ample history stands for allergies, medications currently used, past illnesses or pregnancy, last meal, events or environment related to the injury. Each region of the body is completely examined. NB. All trauma patients should have repeated evaluations of both the primary survey and secondary survey to monitor response to interventions and to detect new abnormalities. Whenever there is a need, trauma patients should be transferred to trauma treating hospitals. Thanks for listening, and goodbye for now.